Hello, everyone. Today, our job is to show you a distal tibia allograft using suture button fixation. You can see here we're in the right shoulder. We've placed in the lateral decubitus position. There's the humeral head. As we come forward, we can see the upper border of the subscapularis and the biceps tendon. You can see the translucent rotator interval. You can see the leading edge of the supraspinatus tendon. This model, of course, has a rotator cuff tear. As we come more posteriorly, you will start to see the Hill-Sachs lesion. As we all know, when you dislocate the shoulder, the humeral head comes forward and creates this Hill-Sachs lesion against the anterior glenoid rim. As we come forward again, you can see the upper border of the subscapularis. So we're first going to create our anterior inferior portal. We're going to use a spinal needle to help localize that. I'm going to palpate the coracoid here and make our first attempt for an anterior inferior portal. As we enter here, you can see how it's too medial and too high. I don't like that angle of approach. You want to have a 45-degree angle of approach to the anterior glenoid rim. So we're going to readjust. You can see how we have a better angle of approach here. So we're going to make an incision in the front of the shoulder and place our first cannula. This is our anterior inferior cannula through the rotator interval. After we've done that, we want to make our anterior superior portal. This portal is critical. It needs to be anterior to the supraspinatus tendon, but usually posterior to the biceps, or you can work on either side. You can see here how it's a little bit too anterior. You want it closer to the supraspinatus tendon. You can see here I've gone through the tendon itself, so you want to make it just a little bit anterior. I like that. And you want to make this tangential to the glenoid neck. We're going to make an incision here and place the cannula, and we can see how we now have a twin anterior portal approach. Now we're going to view through the anterior superior portal. You can see how the glenoid now is on the bottom of the screen, the humerus on the top. You can see our labrum tear is torn anterior inferiorly and displaced. Here's our Hill-Sachs lesion as well. Normally, I would do a remplissage procedure here, but today our focus is really for the distal tibial allograft. We're going to use an elevator through the anterior inferior portal and slowly release it off the anterior glenoid neck. We want to do this really to the 6 o'clock position. You can see here how we're trying to get to the 6 o'clock position, but it's a little bit difficult. So what we're going to do now is provide a little bit of traction. So this lateral arm holder has a lateral distractor as well. You can see how we can increase the space available. Of course, you can do this in the real situation in a patient by distracting laterally, either through a boom or through an assistant, or you can also put a bolster in the axilla and lever the arm and the shoulder apart. Now you can see how we can approach that 6 o'clock position to ensure we have an adequate release, because you really have to release the labrum quite a bit so that it can accept the bone graft. So now once you've done that, you need to place a traction stitch through the labrum and capsule. Usually place that at about the 3 o'clock position, and you can bring it through the anterior portal or percutaneous accessory anterior inferior portal as well. And then we begin to make a radial cut through the labrum. Usually this is done quite superiorly at about the 2 o'clock position, just anterior to the biceps tendon. And this will actually help open up the pocket to accept the bone graft even better. You can see how we're releasing the labrum even more. And we can see that little curve there is actually the base of the coracoid, which you see almost every single time. Now, of course, in this particular case, there's already a bone defect that has been created to accept the bone graft, so we don't need to actually do any preparation, but normally you would flatten that down to a flat surface. We're going to prepare now for our drilling. We've already placed a half-pipe cannula through the posterior portal, and this is our double-barrel guide. The double barrel guide will essentially help place two parallel tunnels through the glenoid, but its advantage, of course, is that you're going to drill from posterior to anterior so you can avoid the neurovascular structures anteriorly. Usually, clinically, this is positioned just inferior to the bare area. You want it parallel to the face of the glenoid, and the hook goes over onto the anterior glenoid neck. Generally speaking, you don't want to tip it too medially because that will make the drill holes too medially, and then your graft won't be as flush as you might have liked. But this is something that's a little bit nuanced, and you have to learn that in each of your patients, as well as practicing in models, etc. So we're going to now drill our bone tunnels. You can see here we're drilling externally from the posterior to anterior. And the first one we're going to drill is our superior drill hole. You can see it exiting the anterior glenoid neck. This has actually been preloaded with a sheath, and this sheath will actually stay within the glenoid. You can see the sheath right there, and you want to keep that within the glenoid so that you can help pass your sutures and suture buttons. You want to kind of bury that a little bit because the sheath does have some sharp teeth and that can damage some of those sutures. Now we're going to pass the inferior drill and sleeve. You're going to drill again from posterior to anterior. As we exit the front, you can visualize this through the anterior superior portal. And again, you can see the sheath there, and we're just going to back it up a little bit so that it is basically just flush or just posterior to the cortical bone. So now that we've done that, we essentially have to place our anchors for the Bankert repair. And you want to do that with the sheath in the glenoid as opposed to the suture buttons, because if you have the sutures and the suture buttons already there, when you're drilling, you can accidentally damage those sutures. So here we are now, close to that 530 position. We're going to place a drill hole through here. We're going to be using an all suture anchor, a 1.8 millimeter Q-fix anchor. And generally, I'm going to place 3 anchors. I tend to place one low, and then one high, and then one in the middle. So there's our low anchor. We're going to treat the sutures to the posterior portal to get them out of the way. Now we've placed our high anchor, and we're going to place our middle anchor. When you're drilling this, of course, you can inadvertently actually hit your sheaths. So you have to make sure that you're definitely bottoming out the drill. Otherwise, of course, the anchor will not deploy correctly. I usually use 3 anchors. Sometimes you can get away with 2, but in general, we'll use 3 anchors in this particular fashion. I do believe the smaller the anchor, the better, because I want to have as little as possible at the bone-to-bone interface with the graft. You have to bring these all out through the posterior portal for suture management as we begin to prepare for the shuttling of the graft into the joint. Okay, now we're going to go to the side table and prepare our distal tibial allograft. Tactile will actually make you a distal tibia so you can practice harvesting it from the distal tibia, making a graft of the appropriate size. In general, it'd be about 2 by 1 by 1.5 centimeters, but of course you have to tailor this to your actual defect and the size of the patient. In this particular case, we've drilled 2 bone tunnels for 2 suture button constructs. Some people, of course, have gotten away with a single suture button construct, particularly when using a coracoid bone graft, but in this particular case, we've done 2, which I think can be a little bit more rotationally stable. As we place the second suture button in, you have to make sure that these buttons are inset into the actual drill hole so that they are flush against the bone per se. I think as we get more and more experience, most of our bone grafts are actually getting smaller. You can see here how there's cartilage and cortical bone as well as cancellous bone. Okay, so we're going to go back into the joint now, and we're going to pass our shuttling sutures. We've passed one first through the inferior bone tunnel, and we're going to bring this through the anterior portal. It's super careful here to make sure there's no twists when we have the second one in as well, because otherwise it's going to rotate your graft. So it's good to separate these as they come out through the cannula. Okay, so once we've done that, it's time to shuttle our graft. We can place our sutures through the black shuttling loop and pull them posteriorly. I usually like to start with the inferior suture button construct just because it's easier to see when it's the first one. Then we start with the second, more superior one. While you're doing this, you want to make sure that there's coming in easily and there's no soft tissue interposition into the tunnel itself. In this particular case, we're going to advance our graft as we continue to pull our sutures posteriorly. We're using the coracoid grasper percutaneously through the anterior rotator interval. Once we've done that, we want to provisionally reduce our graft. We have to make sure that the capsule isn't interpositioned and preventing from seating of the graft more medially. So we want to pull that capsule away from the glenoid neck to create a pocket so that the graft can be reduced medially. So once we've done that, you can see how the graft can be flush with the glenoid face. You can see here, we're going to try to provisionally reduce it a little bit better. This graft is a little bit long, which is preventing the reduction of the most superior portion flush. You can see it right there, but we're going to do the best we can here and manipulate it a little bit more. So once we can see that we can reduce it in a reasonable fashion, we're going to start securing the graft posteriorly. So in this particular case, what we want to do is place a suture button posteriorly and then essentially tie a nice knot. As we secure the knot down against the posterior glenoid neck, we want to make sure our reduction is reasonable. We can do some minor adjustments in that fashion. I usually start with the inferior suture button first and then do the superior one as well. You can tension now your sutures posteriorly. You can see how we've added the tensioner to the inferior portion of the graft construct, and now we're going to add it to the superior portion. We cycle this back and forth multiple times, up to 100 newtons, to essentially take all of the slack out of the system. Once we've secured that, you can do your finalized graft positioning, tension it, and lock it with 3 reversing half hitches on alternating posts. I like to keep my grafts extra-articular, so we're going to repair the labrum and the capsule back to the original glenoid face so that the graft is extra-articular, and it also, of course, repairs your Bankart lesion as well. So we're starting with the inferior anchor. We're going to pass our sutures through the inferior labrum. You can see here, getting right to that 6 o'clock position using an antegrade suture passing device. Of course, you could always go from the posterior portal and use a hook to the left to a similar type of bite. I find that usually we can do this with an antegrade suture passing device as long as you've released your labrum sufficiently. Once you've passed all your sutures, then you can essentially tie them, and you can see as we tie the knot down, the labrum gets shifted over and on top of the grafts, making it extra-articular. So here's the final construct. You can see the Bankart lesion has been repaired on top of the graft, making the graft extra-articular. Thank you.